Hi, and welcome to Rad Onc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria, and I am finishing up my PGY 5-year at the University of Pittsburgh. In our previous physics lectures, we have talked about properties of photon beams as well as properties of electron beams. And I would say that on board exams, questions related to photons and electrons are probably much more common than those related to protons. However, I do think you can expect at least, a couple of questions related to protons, just because although not every place has access to proton therapy because it's very expensive, it is something that, we should be familiar with. Patients ask us about it, and we should know, generally when we might consider referring somebody to a proton center. So in this talk, I'd really like to just focus on the physics of proton beams and talk about different things that might potentially come up on physics board exams with regard to protons. And in this discussion, we will kind of hit on some of the advantages as well as some of the limitations of protons. And hopefully that can help with the understanding of, when we might think about actually referring patients for proton therapy if we don't have it at our own institution. And huge caveat to this talk is that I did not train at a proton center, so I'm sure there are a lot of people out there that did and that work at proton centers that have a more nuanced understanding of these topics. My goal here is to really just focus on the very basic physics of protons. The most important thing to realize about protons is that its depth-dose curve is really different from what we see with photons versus what we see with electrons. And that all falls back to their fundamental properties, which is their mass. So remember, photons are massless particles, right? Photons are the X-ray treatments that we use on a linear accelerator, and photons are massless particles. So a massless particle can probably travel very, very far because it doesn't have any mass to it, so there's really nothing to stop it. So if we look at this depth-dose curve, the blue line represents photons, and what we see is that as photons get deeper and deeper into the body, their dose falls off because the beam gets attenuated. But you can imagine this is just showing up to a depth of 30 centimeters. But although the dose is much less than what the entry dose was and even what the depth of maximum dose was, there's still going to be a significant contribution from exit dose. And if you have multiple beams, then that dose can kind of add up and there can be, a significant amount of exit dose with photon beams. Electrons, on the other hand, are very, very light, right? So it's important to know what the resting mass of an electron is, and it's 511 kilo electron volts, or 0.511 mega electron volts. So electrons are particles, but they are very lightweight. They're not as lightweight as photons. They do have a mass, but it's an incredibly low mass. And so because of that, they deposit most of their depth very superficially, and then the dose kind of falls off. And once it falls off at a superficial depth, deeper into the tissue, there's very minimal dose. So electrons, we often use them to treat superficial targets. For example, if we're treating skin cancers. Protons have a mass that's about 2,000 times that of an electron. And so the resting mass energy of a proton is 938 mega electron volts. So again, about 2,000 times that of an electron. As a result of that heavy mass, protons have a much different depth-dose curve compared to photons or electrons. Instead of kind of slowly depositing their dose as they go through the body and either depositing it all superficially or like electrons do, or continuing to move through the body the way photons do, I think of protons as like a big, heavy bowling ball that's just hurtling through the tissue, but it's on a mission and it doesn't really deposit much dose until it gets to its target point or its stopping point. That stopping point is defined by the energy of the proton beam. So higher energy protons will go to a deeper stopping point. But once it hits that stopping point, that point is where protons deposit nearly all of their energy. And then beyond that, there's hardly any dose at all. And so they have very, very little exit dose. So that phenomenon where protons deposit most of their energy at a defined depth, that is known as the Bragg Peak of protons. So protons have what is called a Bragg Peak, which means at a given depth, which is determined by the proton energy, those protons will deposit all of their energy there. And so you can imagine, because protons deposit all of their energy at a particular depth, and because they have very little exit dose, in fact, they have minimal exit dose, they can be considered very advantageous in certain clinical situations. So that includes very often pediatric patients where we want to minimize the exit dose and help decrease the late toxicities that they experience, as well as their secondary risk of cancers because they have many, many decades left to live. And in certain adult cases as well, it can be an advantage. For example, craniospinal irradiation comes to mind, where if we can minimize the exit dose from a posterior beam and prevent all that bowel that's anterior to the spinal cord from getting radiated, we can help minimize a lot of GI toxicity and help patients kind of tolerate their treatment better. So that is why, protons in certain clinical situations might be very advantageous and why they have been explored. So protons are generated in these machines called cyclotrons or synchrotrons that are these gigantic machines that are very, very expensive. Essentially what happens to the protons in these machines is that they get harvested by a deflector, which generates this electrostatic field, and that redirects the protons out of their centripetal motion. So the difference between cyclotrons or synchrotrons is kind of how these particles are accelerated. In cyclotrons, they are accelerated in a spiral path, and in synchrotrons, they are accelerated in a closed loop path. But these machines generate protons, and then they kind of get directed to a treatment room where patients are treated with proton therapy. Here are just some example photos showing what a cyclotron looks like. And in the image on the left-hand side, we can see those particles getting accelerated in a spiral path. And then in the image on the right-hand side, we can kind of see a diagram of the cyclotron room that's accelerating the particles, and then the actual arm that's going into the treatment room where the beam sort of exits and treats the patient. One thing to keep in mind with protons is that the relative biological effectiveness, or the RBE, is different compared to that of photons. So recall from a radiation biology talk that I recorded previously, the relative biological effectiveness in sort of layman's terms is defined as the dose of 250 kVp X-rays that would be required to lead to the same kind of efficacy or effectiveness as whatever particle is in question. So for protons, that calculation comes out to 1.1, which means that I kind of think of it as protons are a little bit stronger than your normal radiation because their RBE is 1.1. For reference, the RBE for carbon, which is a much heavier particle, is 3 or higher. Okay, so the RBE I kind of think of it as almost like a strength, right? It's how many 250 kVp X-rays would you need to get to the same effect as the particle in question. So for protons, it's 1.1. For carbon, it's 3 or higher. And so when we think about protons, we actually have to multiply the photon dose by 1.1 to account for the proton's relative biological effectiveness. And when we report dose with protons, there's different ways to do it. So what you can do is report the dose as a cobalt gray equivalent, a CGE or just a gray equivalent, but keep in mind that this does not qualify as the SI unit. When we report our dose to the ICRU, the dose in RBE is what should be reported. So that is just something to keep in mind. But it's very important to realize that the proton RBE is 1.1. I want to go back now to this concept of the Bragg Peak, which we just mentioned a few minutes ago. And we said that like any other, particle that we use to treat, as a proton traverses through tissue, it loses energy. The difference between protons and other particles and photons is that at some point when the proton loses all of its energies, it just stops. And it's not a gradual loss of energy. It kind of deposits most of its energy right at the point where it stops. And then there's very minimal exit dose. So rather than kind of a gradual slope, the way that we see with photons and with electrons, what we see is sort of a straight line at a lower dose and then a big peak right where it deposits that energy and then no dose thereafter. And that is known as the Bragg Peak. And if we treat with a higher proton energy, then we will get deeper penetration and that stopping point will occur deeper into the tissue. So the higher the proton energy, the deeper the penetration. If we have a monoenergetic proton beam, meaning a proton beam that's all made of the same energy, we will have what is known as a pristine Bragg peak, and that is shown in figure A on this slide. So see how the dose is kind of low in the beginning, and then we see the Bragg peak at that final depth, and then all the energy kind of drops off. And you can see what's happening to the actual proton energy as well along this curve. But all of the dose gets dropped off right at the end, right where that Bragg peak happens. Now, the issue with the pristine Bragg peak and the issue with using a monoenergetic proton beam is that tumors are not linear, right? They don't start perfectly at one depth and not go further. Tumors are three-dimensional, and they actually kind of have a depth to them. And so we need to treat the entire depth of the tumor. If you look at figure A, they're showing kind of what a hypothetical tumor thickness could look like. And we're seeing that with the monoenergetic proton beam and that pristine Bragg peak, we're missing most of the tumor because all that energy is just getting deposited right at the end. So what we can do is think about spreading out the Bragg peak by adding additional proton beams of many different energies. So this is what is known as a spread out Bragg peak. And if you look at image B, you see an example of that. And now by using multiple energies of protons, we have kind of spread out that Bragg peak by using multiple energies, and we are now covering all the thickness of the tumor. We still have a very sharp fall off at the end, and there's very minimal dose to the deeper tissues beyond the thickness of the tumor. The downside, though, is if you look on the flip side, the shallower depths, and you see what happened to the relative dose at the depths prior to where the tumor was located, and see how that line got raised and the relative dose became higher. So now our skin dose and our superficial dose is also increasing because all of those polyenergetic proton beam doses, that superficial dose is also kind of adding up now. So yes, with a spread out Bragg peak, we get to treat the entire thickness of the tumor, but at the cost of also slightly increasing the skin dose and the superficial dose to the patient. But the fact is that if we want to treat the entire thickness of the tumor, we really do need to change the energy of the proton beam so that we can create that spread out Bragg peak and properly treat the entire thickness of the tumor. So how do we do that? What are some ways that we can change the energy of the proton beam and make sure we're adequately covering the tumor? So one of the methods, which is an older method, is this method known as passive scattering. And in passive scattering, this technique uses something called a range shifter, which determines the highest energy of the beam, and a range modulator, which introduces various degrees of thickness to alter the energy of the proton beam to create that spread out Bragg peak. So basically, with a range shifter and a range modulator, what you're doing is you're taking a proton beam of X amount of energy and you're kind of adding layers in front of it to alter the energy of the proton beam so that instead of getting a monoenergetic beam, you're getting a polyenergetic beam, and that will then be able to treat the entire thickness of the tumor. Now, if you look at the image that I have here, it's really a proton pencil beam that is being shined. And so we need to actually treat not just the thickness of the tumor, but the entire width of the tumor as well. And so different scattering foils are actually placed within the line of the field to help widen the beam. And for larger fields, we might even use dual scatterers. So as you can see in this image, there's the first scatterer, and that helps to kind of widen things a little bit. And then there's a second scatterer as well, which helps to widen things more. And then there's also, things called compensators that help to make the shape a little bit more conformal to the target. And that is how passive scattering is used to kind of alter the energy of the beam using these range shifters and range modulators, scattering foils in the line of that pencil beam. And the downside of this method is that we end up with a higher surface dose because, as we saw, when we use a polyenergetic beam, the superficial dose of all of those beams kind of adds up and it increases our surface dose. But this is one way to treat the entire thickness of the target, and then we use scatterers to cover the entire width, and this method is called passive scattering, and it's kind of an older method. A newer method, which I think is preferred by the newer proton centers that are popping up, is this method of active scanning, also called spot scanning. And this uses what is known as a pencil beam technique. So in passive scattering, a pencil beam was being shined and it was purposely being scattered either once or twice to make the entire field wider. So when we needed to treat to a particular thickness, all of the skin in that area was kind of getting a higher thickness dose. With the active scanning or the pencil beam technique, a beam that's theoretically as thin as a pencil can kind of precisely be directed to various spots within the target. And so the beam is literally just pointed to one spot within the target. There it releases its maximum energy, and then it moves to the next spot and then the next spot, and it kind of slowly works by painting the target. And there are some videos of this available online if it would be helpful to kind of see it in action. The advantage of this is that we get improved proximal dose conformity. So rather than having everything that's proximal to the tumor just get blasted with a higher amount of radiation, we can help generate some conformity more proximally and kind of help soften the skin dose compared to passive scattering. And it can be done, fairly quickly. Machines can do about 1,000 spots in about 60 seconds. The downside with active scanning or spot scanning or pencil beam technique, whatever you want to call it, is that tumor motion is more of a concern. So if you are so precisely, with a pencil beam painting the dose along the target, you can imagine that if that target were to move, that can definitely lead to some uncertainty. So this is kind of, I think, a newer method and a preferred method for newer proton centers that are popping up. They still use a range shifter plate, but the difference is that instead of using a scatterer to kind of make the entire field get the same kind of proton dose, they're using a pencil beam and kind of delicately painting the target. So as we mentioned earlier, there are definitely advantages to protons, and the main advantage is that minimal amount of exit dose, which can really be helpful for sparing long-term toxicity and risk of secondary malignancy, and just helping to make treatment more tolerable for patients. And if we're treating pediatric kids that have a very good prognosis, I think that is probably one of the strongest indications to refer somebody to a proton center. If it's a child with a tumor where we expect them to live for a very, very long time, for example, medulloblastoma comes to mind, where they get craniospinal irradiation, it can really kind of help mitigate toxicities. And there's actually evidence that patients do better when they're treated with protons, specifically for medulloblastoma. In adults, I think in some cases it can be advantageous if we have access to it, for example, craniospinal irradiation. But there are many cases where protons aren't necessarily advantageous. And one example that comes to mind is prostate cancer, where we actually had a recent study that was presented at ASTRO, the particle study or the party QOL study, where they looked at the quality of life between patients that were treated with photons versus protons for prostate cancer, and they essentially found no difference. So it's not always advantageous. And in fact, because protons are actually quite sensitive, they can lead to many uncertainties as well. And so it's not always better to use protons. If used wisely and if used for the right cases, it can certainly be an advantage, but it's important to understand its limitations as well. So what are some of those limitations? Well, one of them is the sensitivity that it has to tissue inhomogeneities. So figure A and figure B show a cobalt-60 curve versus a charged particle curve, a dose depth curve, and what happens to the curve if there's 3 centimeters of bone placed in its path. So for the cobalt-60 curve, this is a photon treatment, you can see that there's about an 11% change in the dose at that particular depth because of the bone being introduced. If you look at figure B, however, with the charged particle and introduce 3 centimeters of bone, the maximum depth where that tissue deposits its dose is actually drawn in by about 2 centimeters. So the distal edge of our dose is shifted 2 centimeters by having 3 centimeters of bone in the path. And so this applies not just to having bone, but also to having any metal artifacts after surgery, if patients have chemo ports, and so on. And so we have to be very, very, very careful with protons with regard to these things that can introduce tissue inhomogeneities, because that can really affect where the distal edge of the dose is deposited, and you don't want to miss. You don't want to overtreat, but you certainly don't want to miss your target when you're treating with protons. In addition to these tissue inhomogeneities, protons are also more sensitive to different anatomical changes with patients. So for example, if they have weight loss during treatment, if there is motion during treatment, if there are kind of air and soft tissue interfaces, because they travel differently depending on the different, tissue densities, like air versus soft tissue versus bone. And that is very, very important to account for. I think with photons, although we account for these, when we're in our algorithms, there is, I think, a little bit more forgiveness there because photons are going to be penetrating all the way through the body nevertheless. So photons definitely have more forgiveness when it comes to these different tissue inhomogeneities for sure, with regard when compared to protons. Additional limitations of protons, if there's any uncertainties in the CT Hounsfield units and the density calculations, that is a factor, as we just talked about, with tissue inhomogeneities. There can be differences in the stopping power, there can be some range uncertainty, and all of this is really, some of the uncertainties that we have to think about with protons. And one thing that centers will do is that they might actually add a distal margin, so more margin at the distal end of the beam, just to ensure that their target is fully covered. So an example of what that formula might look like is shown on this slide, but the exact formula might vary between centers. But essentially what they do is just, if they know which way their beam is entering, they'll add just an additional margin on the distal end of that beam to account for that range uncertainty and uncertainty of stopping power. So this is just sort of, I think, a teaser to the different sensitivities and uncertainties of protons. If you actually work at a proton center or if you rotate at a proton center, it's helpful to see some examples of cases where protons might not be the best idea. And, I think with photons and with VMAT therapy, if there's something that we need to kind of curve our dose around, if there's a very critical organ at risk that we need to protect, VMAT technique with photons is actually much better at kind of creating that curvature and carving dose out of particular places. I think of protons as kind of like a heavy-duty truck, and it's much harder to turn a truck around a sharp bend compared to like a really speedy race car, which is what I think of as photons as being. So there are many limitations with protons, and big takeaway here is just that protons are not always the answer, and sometimes photons might even be better. So then just to wrap up and kind of summarize generally what I think you should know at the very baseline about protons to prepare for physics boards. Protons are generated in these cyclotrons or synchrotrons, which kind of accelerate these proton particles. The protons have an RBE, or a relative biological effectiveness, of about 1.1. So we have to multiply the photon dose by about 1.1 to account for the proton relative biological effectiveness. And we can report the dose as cobalt gray equivalents. When we report to the ICRU, we do need to report kind of the RBE weighted dose. Protons are advantageous because they have a Bragg peak where they deposit most of their energy at the depth at which they stop, which makes them particularly attractive for pediatric cases. Monoenergetic beams will have a pristine Bragg peak, so all of the dose is deposited at a specific point. Polyenergetic beams will have a spread out Bragg peak because the higher the energy of the proton beam, the deeper the depth at which it deposits all of its dose. So we typically do need a spread out Bragg peak in order to treat the full tumor thickness. And there are some techniques for changing our proton energy to be able to treat the full tumor. So the older method is passive scattering, where we kind of put scattering foils in front of the pencil beam to spread out the dose. And we also can put these things called range modulators to change the energy of the proton beam and get our spread out Bragg peak. The newer method that is more preferred now is active scattering or spot scanning, also known as the pencil beam technique, where the pencil beam of protons is not scattered, but at different energies, it kind of specifically paints the target to be able to cover the entire target, and it helps it, have more conformality, especially proximally. So more superficial conformity, basically. And then finally, as attractive as protons are in certain scenarios, they are still very sensitive, and there's many uncertainties that we do need to think about. So they are very touchy with regard to tissue inhomogeneities, tumor motion, if there's any anatomic changes such as weight loss. We have to think about any uncertainties in our CT numbers, stopping power, and also range uncertainty. So protons are great, but we do need to really think about when we need to use them and make sure that we are accounting for all of these different limitations. That brings us to an end. It's all I have on properties of proton beams. Remember, I'm not an expert physicist. I'm no expert in protons, but here I was just sort of trying to share some of the very basic things about protons that might pop up on exams. And hopefully this was a helpful overview of different properties of protons and also limitations of protons. So with that, I wish you the best of luck with studying, and thank you so much for your time and attention.